Good morning, ladies and gentlemen. Welcome once again to the 6th Veterans Mental Health Conference on Policy and Care, which would normally be held in the Great Hall of King's College London, but for reasons that are beyond me, unfortunately won't be this year. Now, this is the 6th conference that we've held. It's becoming a bit of a fixture in the calendar. It's always been very good value because of the support that we get from Forces in Mind Trust. And once again, we thank very much FIMT for all their support. But it can't get any cheaper this year because it's actually free. But I do hope and pray this will be the one and only meeting that we have on one of those evil twins, Zoom or Teams. And actually, as Neil Greenberg has just reminded me, it's exactly 1 year ago precisely that I was supposed to chair the introductory session of this, but was unable to do so because my wife had just tested positive for the virus and was one of the first people to have to quarantine because of that. Just goes to show what's happened in a year, very little of it good. Now then, this conference has been the place to be for quite a while. Sadly, this year, though, we won't be welcoming Prince Harry, so you'll all miss the opportunity to witness him being rude to me, which is probably the main reason you've come. But we continue to have an all-star cast. And it's particularly fitting that today we've had a change to the programme, for those of you who've seen the programme, because we've got an important announcement will be coming from our Veterans Minister, Johnny Mercer, who's here today, and the boss of NHS England, Simon Stevens, also here today. And this is something that, as Kate Davies will be our third speaker, will confirm, this is something that we are really proud of because this conference has played some role in catalysing over the last few years the announcement that Johnny will be making. So it is fitting and very welcome that he's here and we're here. Now, before we do that, a couple of things. We're going to move fairly swiftly, but there will be time to ask questions when we've heard from our opening speakers. So please submit your questions via the live events Q&A. Please do upvote them. Is that a word, upvote? I don't know. Anyway, there's the ones that will catch my eye, but I'll also try and select other questions if they're particularly interesting or amusing. We're recording this meeting, of course. Anyone who needs captions, press the closed captions button. I've no idea what that is, but press it if you want it. Tweet, please, on hashtag VMHC2021. Okay, now let's get on with the launch of what's called Op Courage. You may not know what that is, but you certainly will in a few minutes. And who is going to be doing that? Well, first of all, our Minister for Defence, People and Veterans, Johnny Mercer, been in the post since 2009. Johnny is not your normal minister, and I say that with genuine admiration. He has unbounded enthusiasm, commitment, and is a breath of fresh air. Now, he's starting with a video. That normally means that he's too busy to turn up here, but it does not mean that today. He's very much here and I can see him here. It's just he doesn't trust dodgy Devon Wi-Fi. Who can blame him? And this meeting is too important to him, and indeed us, to have such petty problems. Then we have another Simon, Sir Simon Stevens. I haven't got a bio for Simon, but I do know what job he used to do. He was my local Lambeth councillor. I've lost touch with him since then, so I'm not sure what he's up to now, but no doubt he'll tell us. And then we have the magic that's Kate Davies, originally a probation officer, now the Director of Health and Justice, Armed Forces and Sexual Assault. Probably the hardest job in NHS England, I would say, even harder than Simon's job. She's been at it since 2012. She, as I say, she's quite brilliant. The only person that I've seen who's had the Defence Select Committee eating out of her hands. Now, to start, one of the amazing things about Kate Davies is her total commitment to embed service users in everything that she does, and therefore everything that we do, both at local, regional and national level. And when she commits to something, it happens. And therefore, we're going to start with a short video from an Army veteran and service user, and we will continue to do this on all the 4 mornings of the conference, at different ones, I should say. So first up, if we could please go to Mark Foster. He's happy to identify himself, as you will see, and he will introduce us himself and he will kick the conference off. Off we go.
When I was trying to leave the military, it was very hard for us to tell people how I was feeling. I felt ashamed. I felt like a failure. Hi, I'm Mark Foster. I served with the RLC from 2008 to 2012. I lost a friend due to him driving over an IED. I tried to hide my feelings, started having panic attacks. I just wanted to leave the military. At first I thought I was I was all right when I came out. I started realising I had a few unusual behaviours. I was isolating a lot. My anger was through the roof. The way I got around this was to drink alcohol. I was drinking 2 litre bottles of vodka a day, neat out the bottle. I would have arguments with my ex-partner, who I've got my daughter to. I was fighting all the time. I was forever getting arrested. I had to sleep rough through the winter. It was at that point where I had to speak up and get the help what I needed. I got offered help with alcohol recoveries. I just didn't feel they understood us. It started getting to the stage where I was self-harming, and that's when I got put in touch with TILS and working with the wounded. It was a big relief and like a weight off my shoulders. I was speaking to people who understood me. They put us into a charity-run rehab, which is based on military, and it was the best thing I've ever done. It was structured. It just felt comfortable with the people I was around, being ex-military. Yeah, I think the high-intensity service is a brilliant idea. I think it'll help the NHS to learn a little bit more about how a military person works. I feel absolutely top of the world. You know, I'm healthy, I've got a roof over my head now. I see my daughter again. Life's much better.
Thank you very much indeed. And now we're going to cue in Johnny, but as I say, Johnny is live, but this is his recorded video, and that should now, can we go on to that please, Milton? Got a lovely picture of all our wonderful guests here, all looking very solemn. And slightly ironic, Johnny. We were hoping this was to protect you from Wi-Fi problems at your end. Here we go. Right, good. Cue Johnny, and cue Johnny's voice, please.
Good morning. The video you have just watched underlines why we are all here today. The impact of poor mental health is devastating to individuals, to families, and to all of us as a veteran community. But the uplifting conclusion reminds us we can all make a difference. It also reminds me of the urgency we have in meeting the challenge of tackling poor mental health. Veterans' mental health needs are not often that much different to the needs of the general population, but it is true that for a long time the UK government didn't take the mental health of the veterans community seriously enough. For me, of course, it's personal. Trying to reset the UK government's relationship with her veterans was why I entered politics. I fought those wars with you, and I promised I would do all I could to change the provision of mental health services to our veterans. At this conference last year, I told you that I wanted to accelerate the high-intensity service, to bring it online as the third part of a clear, easily understood and widely accessible world-class mental health care pathway for our veterans. I'm here today to tell you that we've done just that because of the wonderful staff of the NHS under the leadership of Sir Simon Stevens. And yes, it does require real strategic leadership and a commitment to our veterans beyond warm words, driven by characters like Kate Davies and others who have worked so hard in this sector for so long. Today, I can announce the launch of Op Courage, the Veterans Mental Health and Wellbeing Service. I promised you we'd look at veterans care in the UK differently to how we had done in the past, not marking our progress by how much we were putting into the machine in Whitehall, but how it actually felt to be a veteran in the UK in 2021. There has been some clear progress in recent years. The NHS is now treating over 20,000 veterans a year. With the new high-intensity services online, we'll be spending £16 million per year on Op Courage alone, increasing as more services come on stream to £20 million a year baked into the long-term plan for the NHS. And with over 870 GP practices across the country now specifically altering their services to accommodate veterans as part of the veteran-friendly accreditation programme, 59 veteran-aware accredited NHS trusts, the lived experience of veterans across communities in the UK is significantly changing at a pace we have not seen before. I, of course, pay tribute to all of the staff who work in these areas, who I champion at every opportunity. Those who work in delivering the programmes in communities across the nation, those who work so hard in the third sector, often volunteering at huge personal cost, simply because they, like me, believe we should do better by our veterans. And of course, I pay tribute to all of those in the Office for Veterans Affairs. But this launch today is a genuine game changer, harnessing the transition and liaison services, the complex treatment service, and the high-intensity services under OpCourage gives us an opportunity to bring a real, clear understanding of the NHS provision for mental health for our veterans, and a genuine springboard to accelerate and drive forward all of the fantastic initiatives in this area. OpCourage will be the front door to a range of services for mental health issues. Anyone struggling can call or email, where they will get an assessment support with Defence Medical Services if they're transitioning, and an early identification of mental health problems. After that, there will be therapeutic treatment for advanced mental health conditions and psychological trauma, intensive emergency care and treatment if you're in crisis, access to other NHS services, and of course, support from charities and local organisations with wider wellbeing needs. For example, housing, relationships, finances, employment, drug and alcohol misuse, and social support. Informed by partners like the King's Centre for Mental Health Research and Forces in Mind Trust, and crucially driven and designed by service users and their families, there could be no credible reason why every GP practice across this country and every NHS trust cannot know and understand OpCourage, get themselves or their institutions veteran aware accredited, and genuinely be the pathways to access all of the brilliant support OpCourage will provide. Because doing right by our veterans is a national responsibility, a whole of government effort, and indeed a whole of society effort. The Office for Veterans Affairs, working in tandem with the Department for Health and Social Care, will do all we can to design and deliver programmes that can tackle the significant challenge of looking after the mental health of our veterans. But it's on all of us to contribute in our own small way by understanding the pathways, asking our leaders why they're not part of these programmes, but crucially encouraging our veterans to seek help, because help is there. And that is what I want to be the clear message that goes away from this conference, one of hope. Help is available. People do care. The Prime Minister cares. I care deeply. Engage with these programs because you can get better. The Office for Veterans Affairs is engaged in a relentless pursuit of excellence when it comes to veterans provision in this country, and we will not tire in that endeavour. I accept we start from a low base. I accept veterans care was, like I said in 2015, a stain on this nation. But that is changing, slowly, surely and irreversibly. Engage with the programmes, seek help and speak up. Indeed, have courage.
Okay, folks, as you noticed, been a slight technical hitch. The joys of lockdown. And as ever, when this happens, a sudden pouring in of various solutions, which I'm never quite sure which is the one we should follow. So, Johnny, you're live. Good. Switch your microphone on.
Right. Would you like me to summarise what we have just seen?
Just fantastic.
I think that would be a good idea.
I want you to do.
So, yeah, no, thank you so much for tuning in this morning. Essentially, what we've done this morning, and we'll post that video online later, is this time last year, I stood on the stage and talked about how I wanted to deliver a coherent care pathway for our veterans when it came to their mental health. And we all know we've got some wonderful services in the transition liaison service, the complex treatment service space, the high intensity service that we've been rolling out actually since the autumn was something I wanted to accelerate, so that by this time this year, we would have a clear, coherent, professional care pathway when it came to mental health in the NHS for our veterans. And today, clearly, we're pleased to be able to say we've done that. Under what we're calling OpCourage is going to be essentially a front door for the NHS mental health services. We are clearly going through a transition in this country at the moment where you have an increase in demand that we're seeing and expected after the operations in Iraq and Afghanistan, and clearly a decrease in the capability of the third sector, who've done so much for so long, but you know, are in immensely challenging times. So the future of veterans care, particularly around mental health, was always going to be a blend, if you like, of third sector and statutory provision, and that is what we've achieved with this. I of course pay tribute to Kay Davies and others who've done all the work, and I particularly want to pay tribute to all the staff who work in this up and down the country, because there is this narrative that you know, we work really hard against, that there is no help out there for veterans and so on. It is, of course, not correct. There is a lot of help, but I accept that it is difficult to navigate. It is difficult to know where to go. It is difficult to have a coherent care pathway, and that's what we've done with Op Courage. So I'll let Kay Davies speak more to it in a moment, but I just really wanted to pay tribute to the staff who work in it day after day, who are on the front line of dealing with what is a very challenging cohort of people, sometimes who are very vulnerable, and genuinely trying to get them better, and working so hard with them in services across the country. And actually, I pay tribute to King's for the work, and Forces in Mind Trust for the work they've done in this space, and of course to Simon Stevens. The reality is, in this country, that veterans care has always been something that people feel like they want to do, but it has kind of stopped there for a little while, until recently, and under the leadership of Sir Simon, we have seen a genuine shift in how this country looks after its veterans, particularly within the NHS, and that requires leadership, and that requires someone to make cognizant intellectual decisions to bake veterans care into the long-term economic plan of the long-term plan of the NHS. That is what Sir Simon has done, and I'm incredibly grateful to him and to others. And the last thing I would say before I hand over, the last point I wanted to make was that you know, there is still, I do still feel that this is a niche issue for too many people, and we all have a responsibility to get out there and talk about the programs that are available for veterans. You know, the numbers of times I sit in my office with a bereaved widow, a child whose father or mother has taken their own life, and they tell me there is no help available for them. It breaks my heart, because there is so much good stuff out there, so many people working hard, but it's a national responsibility. It is not just down to one individual or one office for Veterans Affairs. It is a national responsibility to look after this country's veterans. And I would encourage everybody to find out about Op Courage, what it is, what it represents, the opportunities that are there, the services that are available, so that we can really do our duty by those who have served. So thank you very much, Simon, and I'll pass back to you.
Thanks very much, Johnny. I can understand why you made the video, but as ever, when you just start talking, you are so fluent. That was lovely. Thank you very, very much. Okay, over to my local councillor. That's you, Simon.
All right. Okay, well, look, thank you, Simon. Thank you, Johnny. Thank you, colleagues, for joining this event. This is obviously at a moment of acute pressure across the health service, and it's over the last year a time when, frankly, the relationship between the NHS and the armed forces has deepened from already a very strong starting point. As we speak today, we have seen the number of severely ill coronavirus patients in the hospital halve over the last 3 weeks, which is very pleasing. We are now just below 10,000 very sick COVID patients in hospitals across England, which is where we were at the beginning of November. And a big part of the reason for that is the success of the vaccination rollout, which is a joint endeavour between the NHS and our partners, particularly including expertise in the from the military embedded alongside NHS colleagues. So that, together with other programmes such as the Step Into Health programme, where we've been looking to provide fantastic opportunities, job opportunities for people leaving the armed forces to come into the NHS, that was already kind of part of our lived reality. But obviously what we're discussing today is the special debt of gratitude that we owe to those who have risked all for their country, and the NHS needs to and is determined to play our part in honouring that. look, we know that anybody, many millions of people across this country are affected by mental ill health, but armed forces veterans may have experienced things that thankfully very few others will. So the purpose of today is, I think, to be very practical about where we are on this journey, the advocacy, the vigour, the authenticity that Johnny Mercer has shown in advancing this agenda across the health service, supported by my colleague Kate Davies and the wider team, I think is making a huge difference. We are beginning to see the pillars of a comprehensive response and offer put in place. The transition, intervention and liaison services that began back in 2017, seen over 13,000 former members of the armed forces benefiting from specialist care for common mental health conditions, and then supported by another 2,000 people who've had support for more complex problems, the complex treatment service beginning in 2018, and now the high intensity service for those with the most complex needs in points of crisis. But I would say that, picking up Johnny's point, one of the other things that I've come to realise the military and the NHS have in common is a love of acronyms, of complex descriptions of what should be blindingly obvious. And so part of Op Courage, and this is very much Johnny's insight, having worked with charities, the third sector, service users, is that it's all very well having the building blocks, but if they are not understood and easily accessible to families and individuals, then it is a tree falling silently in the forest. So Op Courage is about showing what those pathways into these services look like, backed by, as Kate will describe in a moment, a forward view for the next several years as to 9 commitments alongside this that the NHS will be making. And we realise that we can only do that as a massive partnership with veterans, with the third sector, with NHS colleagues who are providing these therapeutic services. But frankly, this is hugely important for all of us, and it has our complete commitment. Thank you, Simon.
Thank you very much. That's great. And now moving on to Kate.
Good morning, everyone. I'm just waiting for the... Good morning, everyone. No videos of me, you've got me live, including my bookcase, and on, I believe it's World Book Day today, so I'm very proud to have my bookcase today on World Book Day. And just following on from Sir Simon Stevens and the Minister, I'd agree really with Sir Simon Wesley that over the last 6 years, the conference today, the event today, which I've attended like everyone else in person, has been a real catalyst for us in NHS England and improvement, really to just focus on how well we're doing for the armed forces community. And that means both serving reservists and their families and carers, but also for veterans and their families and carers. And I think looking back, Sir Simon Wesley, we've really managed to move from a position which was supportive and caring, but ad hoc and maybe not consistent, to today's full service of mental health services and a 3-tiered approach with one single point of contact, with an England-wide provision that has grown up over the last few years. There's still more to do, as Sir Simon Stevens says, but I think we wouldn't have got here without doing this 100% in co-production and collaboration with our veterans families and carers, and with our clinicians and providers. And that really has been at times challenging, let's be honest about that, because we haven't always got it right. We've changed direction, we've modified, particularly with the complex treatment service, in getting a service which really focuses on complex trauma which is related to combat. Sir Simon Stevens mentioned that actually 2,000 people had accessed the complex treatment service since its inception in 2018. And if I just give you a little bit of a flavour, that actually means over 23,000 appointments across that 2,000 client group. It is about intensity. It is about a wraparound service. And so I think the element that's really important around Op Courage and the high intensity service and all of those services, now the formal collaboration with armed forces charities. So our NHS trusts who are delivering the mental health services across England are also doing that in partnership formally with a number of military and armed forces charities, which is superb. I don't know, Milton, whether it's possible to put my slides up, and maybe just to put my slide up that just demonstrates the thanks also to some of those charities, but if not, don't worry, I'll pull them out. So the formal collaboration for the high intensity service today for Operation Courage with Tom Harrison House, which is particularly around drug and alcohol support and inpatient support, the Ripple Pond, Walking with the Wounded, Mental Health Matters, STOL, which is particularly helping housing for veterans, combat stress and veterans' mental health, and also all call signs, and many more that probably are too many to mention. So really, I just wanted to make quite sure that that was part of the flavour that we go forward. If we could go on to the next slide, Milton, that would be really helpful. And that will demonstrate really just the thanks to the collaboration. So the second element, and I know time is against us with video faults today, that is really important for NHS England, is to emphasise that in supporting serving community reservists, families, veterans, there's a bit of a two-pronged approach for the NHS. So it's how the NHS understands and supports men and women within the military, both serving, but also pre and post serving, when they access their GP, when they're in A&E department, when they're in a mental health service like the IAP services, where we've supported over 23,000 veterans in the last year. So the two-pronged approach is getting the whole of the NHS really to understand what that means to work and support the armed forces community. And I have to say, particularly their families as well. Their families often take a lot of the pressure, a lot of the hidden support and care of their loved ones, but also looking, and I think we're very proud of this, looking at what the difference is, what the needs are. 11% of our veterans community are women who are veterans. What does that mean with the work we've been doing with Fighting with Pride with the lesbian, gay, transgender community? And what does that mean particularly when we're focusing on a whole cultural support? And I know our Gurkha community have been really supportive in helping us address the models of Operation Courage and the mental health services. So the two-pronged approach is about how the whole NHS supports the armed forces community. The second part of that is how proud we are to have now £17 million worth of veterans' mental health and wellbeing services that are there, free at the point of access. Wraparound services also about whole pathways of care, which Mark's video absolutely demonstrated, and also is there to absolutely make quite sure that we try and make that as close to home as possible, as part of population commissioning, as part of local accessibility, because that is what you've told us. That's what the community of veterans and their families have said to us. They need the range of services that are consistent with that provision and the equity. They need those to be delivered together with the armed forces charities. They need a complete package of mental health care, including that support in crisis, which is where high intensity has been incredibly supportive. And they also need inclusive services that are military aware. And as one of our lead medical director clinicians, Dr. Jonathan Leach, says, and he says often about speaking military. So just moving on to my last slide. Thank you, Milton. So the second part and the last part, Simon Wesley, for today is that we're publishing a Armed Forces community forward view, which is there to ensure that all serving from civilian life and also within serving personnel and their families are getting the commitments that we wish and they have asked for and they deserve. It's really important that those commitments include the strong partnership working, but also identify what that means for families and carers. We've done a large piece of consultation, which is about to go live as a part of family network services across integrated care systems going forward, and how we help particularly in transition. Often the message has been, how do we work with the MOD, with the military, and how do we work with just learning how to be a civilian again? You all know this listening to me today. Those commitments are very much there to embed for the long-term plan, for the years to come, and to support not necessarily maybe the audience today who are very veteran aware, but also for people who may be a little bit nervous, a little bit fearful within the NHS or within collaborations locally, local authorities, mental health services, charities, housing, to work better with the armed forces community, to work with care and to work with kindness and to work with that commitment. So yes, Sir Simon Wesley, it is an important 6th conference today. It's been integral that our lived experience, men and women, children and young people, have helped us to get to this point, and will be as far as monitoring and ensuring that going forward, and improving all the time, and making quite sure that Operation Courage and the support of the OVA, and also obviously massive thanks to Sir Simon Stevens, keeps this very much at the top of the agenda. And in a COVID world, the Military Alliance has been amazing. And we have recently done a lot of work with the vaccines with Defence Medical Services, and making quite sure that our Defence Medical Services are prioritised within the vaccine cohort as well. So this continues, and this is something that I know that my colleagues, thank you very much, working in provider services, charities, and also lived experience, will be really pleased to see embedded, committed and published today. Thank you.
Thank you ever so much, Kate. And we're now
Simon, we do have another video, but I'm just wondering whether you want to still try it, or whether you'd like to move away from it today, and I can just thank Ellie in person.
I think probably thank Ellie in person would probably be the best, actually, and we'll try and play it on another part of the programme, but we have fallen behind for various reasons.
Yeah, I realise that. That's what I thought. But if I just say, people will see at the moment, hopefully, a picture of Eleanor Duke, who's a team manager for the Midlands High Intensity Service within the NHS, collaborating with a number of NHS charities and partners. And I think what Ellie was going to say, and you can listen to it later, as a very proud NHS member of staff, is how much she has learnt, how much she is collaborating, but how important it is to get that crisis care, that 24-hour support, and particularly to think around innovation and support for our veterans within mental health today. So it's really just a massive thank you to the staff within the NHS, but also the way that will be demonstrated in one particular part of the country.
Okay, that's fabulous. Thank you.
I'm Eleanor Duke, and I'm team manager of the East Midlands High Intensity Service, or HIS. The High Intensity Service supports veterans who struggle to engage with mental health services. They often feel misunderstood or not listened to, resulting in them disengaging, and over extended periods deteriorate mental health leads to crisis points mentally and often socially as well. As a service, we recognise the importance of supporting families and carers. We are there to listen, support and directly involve them in care planning for their veteran. The Midlands HIS Pathfinder was co-produced by veterans, carers and clinicians who identified this missing need in mental health care. We are part of an integrated model alongside TILS and CTS to ensure that military-specific assessment and veteran engagement is the forefront of our contacts and care planning. We contact our veterans within 24 hours of initial referral, we risk assess and we arrange further contacts. We also work in partnership with key charities, providing 24-hour access to an emotional support line and specialist addiction recovery. We work closely with NHS services to enhance support, and we want to educate other healthcare professionals on veteran-specific needs. Since Midlands HIS went live on the 1st of October 2020, we've assessed over 90 ex-serving persons and completed 15 carer-specific assessments. Each veteran is individual. However, we've noticed those coming through HIS often have a history of poor engagement with mainstream services, traumatic memories, social care needs, are isolated from friends and family, substance misuse, and have been dealing with negative thoughts to end their life for long periods of time. As a service, it's so important we offer ex-serving personnel and their carers an opportunity to work with a service which prioritises their unique needs. We understand the impact military service has, and we ensure they receive the mental health care they are entitled to, and so often desperately need, as it's not in their nature as veterans to ask for help.
So whilst you're all three here, and I imagine you won't be here for all that long, as there is the NHS to run, we'll move to Q&A. Now, a huge number have already poured in. Some of them aren't questions, so I'll try and summarise a few of them as statements. But let's start with a rather easy question. First of all, you can either answer Martin Nadin's question, which is Op Courage in Scotland, or Matt Kieran, hi Mike, is asking, is Op Courage only in England? So that's a straightforward one. Which is it? Is it England or UK?
It's in England, Sir Simon Wesley.
Call me Simon.
Yeah, Simon. I'm being very formal. I've got too many Simons in one go, and too many Sir Simons as well. So, yeah,
Small Simon.
It's in England, but we're working very closely, as Johnny will highlight, with the Office of Veterans Affairs and the MOD and many charities with devolved administrations at supporting a continuity of care and pathway, and also some very similar models of clinical support within mental health and veterans.
Right, okay, so that's clear. And then this is for you, Kate, well, for anyone, but a straightforward thing. Veterans in prison, how will they access Op Courage?
So, as highlighted in one of our 9 commitments in the Armed Forces 4 review from serving to civilian, one of those commitments is also about working with veterans and families and carers in the criminal justice system. We've also invested and commissioned new services. One of those is particularly called Regroup, which is about the pathway within courts, within police custody, within the prison system, and particularly how most of the time, for many of our veterans that find themselves in the criminal justice system because of offences, they fall into categories of offending behaviour, which often does mean they're so serious that they end up in prison. But also what we're trying to do is look at alternatives to custody and the whole element of the pathway of pre and post custody, but particularly around housing, jobs, and also mitigation circumstances with our colleagues in the judiciary. So yes, it is one part of it. It's a very important part of it, and often is part of crisis as well.
Okay, Simon, Big Simon, that is, how long have we got you for?
That depends on your next question.
Okay, because this is a question for you, but it's a short one. Several people asking lots of variations on the same question, which only you can answer. This is about GPs. Obviously married to a senior GP. They walk on water in our household, but not everywhere. So all of them are saying, what is in this for GPs? Why would GPs do this? And various different variations on that theme.
Well, I think first and foremost, because it's the right thing to do. So we've obviously got, it'll be a relatively small number of veterans in each GP practice. So part of what we're wanting to do is make sure there's good geographical coverage with veteran-friendly accredited GP practices, so that people can actually make choices actually about where they choose to register. But then frankly, we want all GP practices to know what the referral pathways are, whether or not they've gone through that accreditation program. I think we've got 877 practices that already are so accredited. But look, this is a continual work in progress to raise awareness across general practice as to the referral pathways that are available as part of the Op Courage process. I don't know if Kate wants to add to that.
No, I think one of the first things we did was give the commitment to supporting all GPs practices to be veterans aware, and part of that is an accredited programme in partnership with the Royal College of General Practitioners. So even in the last few months within the COVID pandemic, we have still increased the number of GPs that are coming on board, and the request for those now is escalating as we move further into hopefully a period of recovery. So GPs are absolutely integral. Many of our referrals now to the Operation Courage services comes from our GPs. In fact, only one of our lived experience men was talking to me yesterday about it was his GP that actually made him aware and also held his hand in order to get into the TIL service, the Transition Intervention Liaison Service. So GPs absolutely is where we most of us go, and our families, most of us go when we have a problem, when we have a need, when we have a lump, when we have a bump. And that's why we absolutely need to get GPs to be central to this, and they are.
Okay, Johnny?
Yeah, all I would say in response to that is that there is no reason at all why every GP surgery in the country cannot sign up to this. And if there is a reason, I would love to hear it. You know, we are, the Office of Veterans Affairs and people like Kate Davies are working all the hours God sends in order to make these care pathways more accessible, easier, as easy as possible for mental health professionals to sign up to, and for GP surgeries and for hospitals to become veteran aware. If there are barriers, then I want to know what they are. but looking after our veterans is a national responsibility. It's not a hobby horse for some of us. It's a national responsibility. And there is no reason why from today, GP practitioners and NHS staff, particularly within trusts and within CCGs, cannot know what op courage is. And I will be going on a quite a significant push to make sure that it is in every trust in the country.
Okay. Now then, another good question. Stephen James is asking, this is about NHS 111. As the current front door for mental health crisis services, what role will NHS 111 play nationally, ensuring that veterans are guided to the op courage services? Who wants to start on that one?
Okay. This one? Yeah, certainly. So, in fact, we've had a very formal relationship with 111 because when we took over the support and the partnership formal work with Defence Medical Services in the MOD, one of the first things we talked about was out of hours support and how that would manifest itself. And in fact, for our serving communities and their families, that was then also part of Defence Medical Services responsibility. We actually very quickly, within NHS England, then got a formal agreement with our CCGs around the way that 111 would be committed to supporting and understanding the call out nature, because that's basically what we're talking about here, and supporting what that means for veterans and their families. And it's not always in crisis. It's actually also about continuity of care when men and women and families move around the country so often within the military community. That's very much the feedback from the families, and 111 also have been supported to take that up. I think it's an important question because I think one of the things that we do want to do is also prevent people getting to 111 with that crisis. And as you were saying earlier, Minister, you know, making quite sure that everyone also knows where the front door is, as well as 111. But we do have, and I'll continue to work with that formal relationship with 111, Simon. Okay, thank you. Anyone else want to? No, okay. Straightforward, simple one. Simon Adams, who's clearly a very keen question answer, but of course it's caught my eye, just says, who's paying for this? Is it MOD or the NHS? I think that's for you, Simon.
Yeah, no, the NHS is funding this, and rightly so. And indeed, if you sort of track back right to the point at which the NHS was created after the Second World War, it was recognised right from the get-go that there was a special social responsibility across the country for people who had served in the armed forces, and that was obviously renewed with the Armed Forces Covenant and the Act that went alongside that. And now we are recognising the as part of our broader expansion of mental health services, which is happening across the NHS as a whole, the particular needs and resourcing requirements here as well. So I think there is no contradiction whatsoever between saying that we're expanding mental health services in the round and we've got a particular responsibility for those who have served.
So fair enough. Now, I'm obviously attracted to anyone called Simon, but he's asked a supplementary question as well, slightly more complicated. But so with the Armed Forces Covenant and the NHS founding principles in mind, which is what you've just said, are the services provided by the NHS to veterans going to be based on clinical need? Which I imagine the answer is yes. But why then are specialist or specific support services being delivered being delivered as the NHS is for all and not just the specific cohort? I think this is basically a variation on the question of how much is this actually just clinical need, or is there priority for veterans within the NHS? I think that's what Simon's getting at. Where do we draw the line between it's based on clinical need or it's based on your service, your military service? I think I've got that right. Does anyone want to pick that up? It's a question that comes up quite often, actually.
Well, I think it's both. I mean, I think in a way I've just said it, Simon, which is the founding covenant of the NHS was there was a particular responsibility for those who have served, and we continue to honour that principle. But clearly, people are being looked after through op coverage based on clinical need. It's just that there are additional needs, additional complexities that arise as a result of the circumstances that have caused the health requirements that folks have. And it's a complete mistake to think that universal NHS means one size fits all, that everybody has to be looked after in the same way with the same. Actually, if you do that, you end up in a lowest common denominator situation where people aren't having their distinctive requirements looked after. So we've got to recognise the diversity of our patients and tailor services accordingly. And this is tailoring particular services for particular needs. And we do that in other parts of the health service as well.
Can I just come in on that? Because I think one of the things that's really important to make, and we've often, you and I, Simon Wesley, made it at this point, that the majority of men and women who are serving reservists and veterans are healthy, are fit, are well, both physically and mentally. And I think what we're actually doing as part of the question is recognising that actually the best outcomes we can get for our patients who happen to have been in the armed forces community is often also from a military partnership perspective as well. But it has to be also with a very clear eye, and that's why the NHS gave this commitment at your conference 3 years ago, Simon, around the NHS clinical mental health services. And that's what Johnny has been saying all the way through, that it is absolutely part of the work that we're doing to say we are there to support the clinical individual assessment and need, but we are also saying that we can best do that for outcomes when we do that also alongside the amazing services within the mental health field that the Chief Officer for Medical Services, Claire Murdoch, is overseeing. But we can do that with best outcomes for some of our military men and women when we're also doing that alongside people who've been there, seen it and worn the T-shirt. And that's really what we're doing.
Okay. There've been quite a few comments that are very complimentary. Joe Jukes has been very complimentary about the care Till service gave her husband. A few anonymous ones not so complimentary, I'm afraid. But this is one is asking, obviously someone who's working in the services and says, how will things be different for those of us who work in the services, Till's CTS and high intensity service? Will things be different in any shape or form, or will it be the same as it was yesterday? I don't know who. I think that'd be for you, Kate, I think.
Yeah, and I presume, thank you very much for the question. It's a really good question. I presume that's because we're now sitting here talking about Operation Courage and a sort of an overview to the way that the three-tier services work. The difference is that we are now sitting here giving the commitment to the Veterans Mental Health and Wellbeing Service in a way that we've never given before. We've been very honest, and that's probably why we've got some of those comments that may not be as positive around some of the services, that this is an ongoing process of improvement. And some of those have been early adopters and pathfinders. But what we're saying for our staff and for our patients, that this is an ongoing long-term plan commitment, and to make quite sure that we continue to improve. But we also absolutely are ready to ensuring that the mental health trusts and the NHS trust and staff and the collaborative staff that are there with the military partners see this as consistent, as a career, but also very much for the patient's benefit. So I completely understand the question, but I think it's really about the positive embedding to support this for the long term.
Okay. Now we're getting back on track, and obviously I will ask the Minister to sum up in a minute, but this is a rather specific question. I think this is also for you, Minister, as well, directly. New service leavers are given a veterans card when leaving. Good thing. When will the veterans card be rolled out to all veterans?
Yes, it's a fair question. We have struggled with designing a system that is resistant to fraud and resistant enough to fraud. There is a real challenge in this space in terms of the investment that's been put into things like Veterans UK over the years, which is the agency that administrates a lot of the veteran stuff. They are still today working off paper, which is pretty shocking, but it's the reality of it. We've just allocated £25 million to them to digitise what they're doing. And in the next couple of years, you'll see a step change in how that's delivered. My plan is to get it all in the palm of your hand. So you have an app whereby you can take responsibility for your pay, pension, allowances and your care afterwards. Yeah, you know, we're on a journey. We wanted to have it rolled out by now. It's not, but I will deliver that. I'm aware that veterans who've left want it. Obviously, those who are leaving now get it. but I understand the problem, and I will deliver it. I promised I would deliver this today, and I have, and I will deliver that as well.
Okay. Simon, I know you need to go off and save the NHS. Is there anything you particularly like to add? Simon Stevens?
I think really just an enormous thank you to everybody who has not only over the last several years been making the progress that has been made, but everybody who is recommitting today to do what more is needed. Nobody is saying this is mission accomplished. This is clearly a work in progress. I think we've got a lot of energy from Johnny Mercer as the minister involved. Kate Davies is a huge advocate for this agenda inside the National Health Service, inside NHS England, and the wider group of people who are part of this event today. So look, thank you very much. We are on it. More needs to be done, and we're committing to do it.
Okay, and thank you very much for joining us. It's really very much appreciated, given everything else that's going on at the moment. Kate, was that? Kate, you just waved at me. Do you want to quickly sum up as well, and then I'm going to ask Johnny?
No, I was really just kind of thanking Sir Simon Stevens, because it is really important to have had an NHS commitment in the way that we have. We've always had a commitment in the NHS to our armed forces community, but I think, and I know that David and Charles following me are going to focus as well on what that means for not undermining or in any way saying that isn't about what this means for the armed forces charities. But you gave us a challenge, quite rightly, to get this right, and this is exactly what we plan and hope and are doing. And I think it is really important to say that the acute trust, the hospital trust, the GPs and the mental health services need to work together on this as we go forward within the NHS, because as we know, as individuals, we have many needs and conditions around our mental health and our physical health, and it's that collaboration that's really positive. So thank you to everyone.
Okay, and Johnny.
Yeah, I'll just finish if that's all right,
yeah,
Simon,
please.
And a couple of thank yous, and I'm going to be slightly controversial. The issue around the covenant and the NHS, I mean, these clearly are not mutually exclusive, and Simon Stevens dealt with that. It's absolutely right, this stuff's delivered by the NHS. This idea that we're looking to create cohorts of veterans who sort of all hang around together and are treated in mass sort of military hospitals, that is not best practice. And the number one thing that drives us, I'm afraid, in the Office for Veterans Affairs is delivering best practice and improving people's lives who actually need it, not kind of playing to the gallery in designing services that certain individuals think we need. We have to be guided by the evidence. We have to be guided by the experts, like we're seeing today at King's. And I make absolutely no apology for that. There were a couple of comments on there about, are any users involved? This has been predominantly designed by users, and Kate Davies has worked extraordinarily hard to put together a group of users, bereaved widows, and things like that, to ask how do we learn from your experience to make this more accessible and make this work for you. They are driving what we're doing. It's not my ideas, it's not David Richmond's ideas, it's not the government's ideas. It's driven by users, okay, informed by people like King's College and Forces in Mind Trust. And it's really important to remember those as we go forward. The answer in this space was always a blend of provision. Okay, so for those who want the government to pay everything, it's clearly not going to happen. For those who think the third sector should do everything, it's not going to happen. The answer was a blend, and neither of those two things are right. You know, government is too big to do this sort of thing. Third sector have got some amazing expertise, some amazing people. The answer was the blend, and that's what we're achieving with Op Courage. But the last thing I would say is this, is that I've seen a lot of the questions and comments that come in. And for me, it's fair game because I'm a politician. But I must say the names that are sort of denigrating this and others are the same on this platform as they are elsewhere. And all I would say is that we all have a collective duty to make sure that veterans who get poorly, who are vulnerable, who do not know where to turn, know that there is help available. And I'm afraid I feel very passionately against those who would consistently say there's no help available. When there is, because it is a disservice to that individual, it's a disservice to the organisation, but it's a disservice to the wonderful people who work in this area. And you know, I won't say any more than that, but we are turning the tide on veterans care. And the narrative that you know it's all a dog's dinner, I'm afraid that is changing. The evidence shows you that is changing, and we will continue that drive, ruthlessly focused on those who need it. And everybody's welcome. Everybody can contribute. There is a role for everybody. But I will be very robust with those who continually try and paint the picture as it's not, simply not for my benefit, but for the benefit of those people who get really vulnerable and really need it and don't know where to turn. And I make no apology for that. So thank you for having us today, Simon. I think it's an important conference, and I hope the rest of the day goes well.
Thank you very much indeed. Are you able to stay around for a bit?
Yes,
Kate?
I will be on a listening watch. I will, yes.
Okay, and Kate as well. Yeah, that was really good. Thank you. Right, we're back on track. Slightly, only a little bit later. We actually lost David for quite a long time, so he's just arrived. Thank God for that. So it's a great pleasure to introduce Colonel David Richmond. Obviously, the Royal Regiment of Scotland, most you will know, seriously wounded in 2008. In Afghanistan, and I think you lost part of your femur. So when talking about wounded, injured and sick and their pathways, he knows of what he speaks, having tread that pathway himself. Actually, presumably rather gingerly at first, but anyway. He spent several years setting up and running the recovery centres for Help for Heroes, chaired the contact group, of which we'll hear more later, and is now, I've forgotten what you're the chair of the OVA, are you? I've actually forgotten now, David.
No, I'm the director of the OVA.
The director, thank you. I make this up as I go along, so I suddenly realised that you might not be that. Director of the OVA. Okay, David, over to you.
Simon, thank you very much, and sorry for the faff in connecting earlier, but I'm here now.
Least of our problems. All right.
Yeah. So the OVA was set up to champion veterans at the heart of government and to coordinate across government and beyond to make sure that veterans have access to the support they need to successfully transition back to civilian life. I do believe, though, that the creation of the office has to be seen as one of the latest steps in what has been an ongoing journey with respect to how the nation supports and talks about our veterans. It's a journey, I think, that started as the consequences of combat operations in Iraq and then Afghanistan reminded all of us of the human costs of war. And I think it's fair to say that in 2006, the UK had probably largely forgotten what those would be and was ill prepared to deal with them, either in the moment or as would be needed by many for the long term. Since that time, though, I believe we have seen substantial improvements across all aspects of support for veterans, but particularly in terms of mental health support that is available to them. This has included, without question, significantly improved services provided by both the NHS and the third sector. The NHS-led mental health care and support available to veterans across the country, I think, are incomparable to what existed before. And I see the announcements of Operation Courage as only the latest iteration of that, and a welcome one too. And comparing the mental health and wellbeing support provided by the charity sector today to that available in 2006 would reveal an equally staggering improvement, I believe. And I would echo Kate's words, which I just caught as I arrived, around the notion of you said, we did. The degree of collaboration and consultation in developing vets' mental health services is I think, impressive. We do listen and we do act. Sometimes I suspect we don't act as fast as some would like, but it is but it is at the heart, the core of how our services are developed. We spend a lot of time beating ourselves up also, I think, about things that haven't been done yet in terms of mental health support for veterans, indeed across all aspects of support for veterans. And it's entirely right that we maintain a sharp focus on what we must improve and together work hard to ensure that it does. But frankly, I think the progress made in the last 15 years is to be celebrated. It's been a long, unquestionably necessary and often bumpy journey, and it's delivered substantial improvements in care across the piece. It's easy to forget the progress that's been made when we are focusing hard on making the improvements that are necessary. And I really don't say this with the faintest hint of complacency, for we must never cease in those efforts to improve the care and support provided to veterans who need it. And I know that right now, colleagues across the NHS, across the charity sector and at the OVA are continuing to look for ways to improve that support further, and so they must. Continuing improving, though, the mental health services available to veterans needs to be underpinned by accurate data and the insight and information that the very best research can provide. With this in mind, the OVA is working across government to understand what data we already have on veterans, who holds it, what it tells us, and what the gaps are. Further to this, as you know, for the first time, this year's census will ask veterans to identify themselves, and we will then have accurate data on how many veterans there are in the UK, what region they live in, and what their needs are. This is a significant step, and we're already working closely with the Office for National Statistics to ensure we can understand what this data will tell us as quickly as possible after the census closes. And I think that once we get our own house in order in terms of the data held by government, we need to reach out to the third sector to understand how we join this up further, which, while complying with GDPR and other relevant regulations, has huge potential to contribute to the efficiency and the effectiveness of services across the sector. In terms of research, we are building a small in-house team who will develop a research strategy and build strong relationships with the best research institutions in the UK and abroad. And that will help us establish clearly the questions we need answered that can then provide the essential underpinning evidence to support future strategy and policy development in government and beyond. We need to base what we do on evidence and not on assertion. As part of this, we're delighted to be funding the next phase of the King's longitudinal cohort study, looking at the health and well-being of the UK Armed Forces personnel. It's a world-leading study, and it is providing already and will continue to provide an absolute wealth of information about the long-term health outcomes and well-being of UK Armed Forces personnel. And we're also plugged in firmly to the research subgroup of the Five Eyes community, which is continually keeping us abreast of developments made by our closest allies and allowing us to share best practice across international borders. And that also is a strong theme in what we must do at the OVA. I think there is a strong theme here, one of ever closer collaboration, perhaps even integration, in the development and commissioning of key services that comprise Up Courage. I think the NHS has led the way in finding increasingly collaborative ways of working through requiring those trusts bidding to deliver services to include partner charities from the outset. For me, this moves beyond collaboration and into the realm of integration, where we're bringing together expertise from across the sector to provide mental health care and support. And this is a model I think we should be looking to implement where appropriate across the sector, much more widely than simply in mental health alone. With that theme, many of you will have heard me say before that the government's vision to make the UK the best country in the world to be a veteran is the right vision. It's aspirational, it's stretching, and it's achievable. And crucially, and I say this as after a long career as an infantryman, it's short, so you can remember it. And also, you will have heard me say that this is not something that government can achieve alone. And it will require government, the charity sector, and others to work really closely together, much more close than ever before. And the model championed by the NHS has shown us how well that really can work. It provides a place for charities, small and large, to work hand in hand with their NHS colleagues, providing they can meet the required standards of care and governance. And I deliberately highlight small charities in this, many of whom have been doing great work in their local communities or regions for many years. They understand the local situation better than anyone, and they have a great range of local contacts in the health services, local authorities, and elsewhere. That's not to be taken as a slight to the major military charities, who also do great work, but simply to remind us that there is a rich pool of knowledge and expertise that I personally believe, NHS aside, we are not properly recognising or tapping into. And this is something we must address as we look to the future. I also hold in mind the fact that the significant majority of the 14,500 individuals who leave the armed forces every year do so with little or no need of support at all, and go on to lead successful and fulfilling lives. And I think actually helpfully, Kate mentioned this too. Naturally, the focus for veterans for events like this are on those who do need help, and we must ensure that the help they need is there, can be easily accessed without undue delay, and is the very best possible. But we also need to tell the good stories of the men and women who leave with experience and qualifications that should be the envy of employers. Not just leadership, discipline, timekeeping, teamwork, important though they are, but the specialists that exist across the armed services in IT, strategic comms, HR, operational planning, their port operators, plant operators, engineers of all varieties, plumbers, electricians, chefs, joiners, and many, many, many more. A list far too long to set out here. Not only must we shout about these people and improve understanding of what they bring to employers, but we must also ensure that they know where they should go for help and support should they ever need it in future. We must make the whole sector much easier to navigate for those, unlike us, who are not immersed in it on a daily basis. There is a huge amount to do here, and I suspect there'll be some tough discussions to be had and decisions to be made along the way. But have them and make them we must. I'm also conscious that much of what I've said this morning, indeed what many of us have said, could be described as somewhat transactional. Important, undoubtedly, but transactional. Improve this service or that, more of this and less of that, and so on. What we must also address is what I would describe as the transformational stuff. How do we want our veterans community to feel? How do we want them to feel about their service, about how they're left, about how they are regarded by employers and society at large? That's a much bigger question and a much bigger challenge to answer. And as large military operations of the early 21st century fade into the public memory, it is one that together we have got to answer. And I do believe that the continued investment in mental health care, such as that through Op Courage, will help us to answer through contributing absolutely firmly to making our veterans feel valued and invested in. And what about COVID? I could hardly speak without mentioning the dreaded COVID. The financial pressures of COVID have impacted on everyone. COBSIO report that charities have lost something in the region of £250 million worth of income this year and expect to lose the same again next year. And unquestionably, there is less money in government budgets too. But I believe that tough though this will be, we collectively should be looking at this as a catalyst for change in how we operate, and not simply a threat to how we've become used to things being done. If you look back, arguably 2006 was the start of the last strategic impact on the way this nation looks after its veterans, by both government and the third sector, and how society regarded them. In the period since then, huge improvements have been made, but COVID is today's strategic shock. And frankly, if £250 million are coming out of charity budgets this year, and again next, and an inevitable tightening of government budgets is not a catalyst for change, what is? And I'll leave it there. Simon, thank you.
Thank you very much. Whoops. No, I'm not muted. Okay, just for once, I actually wasn't muted. What's really good. So I think people are kind of now settling back down again a bit after the initial furore. But can I ask you a general question about OVA? Now you've not been around very long. So yeah. Let's give you the rest of this year. Okay. What would be the things that we should be looking for to show that you are achieving your goals? What would be the signs that? And I'm not being silly about this. I know it takes a long time, but what do you think would be the kind of the signals that we would be seeing to show that the OVA is making the difference that we've been promised it would? Because it's an excellent idea, no question about that, much needed. Nobody denies that. But how would we know that you're doing that it's getting there?
So a really good question, and I think I'll tackle it in two ways. I think firstly, I think there's a fairly widespread maybe misunderstanding that the OVA will be directly responsible for the delivery of services to veterans, and of course that's not the case at all. We don't operate as a service delivery organisation, and therefore you won't necessarily see the OVA's fingerprints on services delivered on the front line. However, having said that, if you look at things like the COVID Relief Fund, we were central to bidding and persuading the Treasury to commit £6 million to the service charity sector. We then took on the chairmanship or co-chairmanship of the panel who allocated the money, which went to about 100 military charities, which impacted on just over 90,000 veterans, according to the reports we had back. So while you don't see our fingerprints at the far end, our fingerprints are all over it at the beginning. So I think that's an illustration of where we have an impact. But I think also in the OVA has to be operating, I think, at the strategic level. And it's the major muscle moves that will see strategic change in the veteran sector over the coming years. And this would include things I've touched on this morning, such as having a coordinated and effective research strategy that provides the information we need, improves our understanding of veteran needs, and underpins policy decisions and future strategy iterations for the future. It's about understanding and manipulating data well, and ensuring that the analysis is accurate, it's timely, and that we use it to support the development of services. It's about resolving those issues which, to use the words of one of the Veterans Advisory Board members, have been around for so long they're starting to breed resentment, and hastening along the work to resolve those really nutty issues around war widows' pensions, foreign and Commonwealth immigration status, and so on. Those sorts of things. Be the catalyst for change in there at government level. And I think it's also about influencing and funding, putting money where our mouth is for government also, in terms of how can we use our resources, modest though they are, and they are modest, to influence change in the sector, across the sector. When I say the sector, I'm not talking specifically about the charity sector, just the sector generally. How can we be a convening authority that brings together the various players, coalesce around an idea, coalesce around a model of operating, and then lead with them that change? So I think those are the sort of areas you'll see the OVA operating in. And also I think there's an important role for us in talking up the capabilities and the abilities of veterans. And I touched on those, majority of the 14,500 who don't have support needs, and also ensuring that veterans maintain their profile in the highest levels of government. So that was a very long answer.
No, it's good. There's been a specific question. Just say a little bit more about what you'll be doing on war pensions and armed forces compensation. Specifically, do you have the requisite expertise to address those issues within the OVA? So it's a fairly specific question, but I know it's very important.
Yeah, I mean, no, the straight answer is, do we have the expertise to make detailed changes to the pension scheme? No, of course we don't. But that's not why we're there. What we can do is we can understand issues with pension schemes, issues with compensation, and we'll work with colleagues in the relevant departments to explore what the options are for making change, if indeed there is an option for change. That is where we will operate, rather than trying to bring in-house experts in military pensions or compensation schemes, which of course would be folly, to be honest.
All right. And then another question, you mentioned the census, which obviously is very important, but I know it's very, very limited in the questions you're allowed to ask. But this is, someone's worried that that people may not know what the definition of a veteran is. We know it, and many of the people here know it, but they're worried that some of their relatives who have served may just not think that it applies to them.
Yeah, the definition of a veteran, as you know, Simon, is one that pings around frequently, and generally, I have to say, creates far more heat than it does light. I think what's my view on it? We have the word veteran and the image that it creates in people's minds, and that's an issue. And I believe if you're going to change the word for something else, you need to change it for something better. And to date, I don't think we found anything that people would unanimously agree, or the majority agree, is better. You then have the definition, and of course we have the widest possible definition of veteran in this 1 day's service. That means that if we change the definition of a veteran, it can only move in one direction, and it moves from being an entirely inclusive definition to becoming an increasingly exclusive definition. And for every cohort of people you pop the wrong side of the line, you are excluding them from entitlements to certain things. And then finally, I think you've got how you might classify veterans, differentiate between one sort of veteran and another. And you could do that through a variety of means, be it length of service being an example. and maybe through a sort of a categorization of veteran, you vary the degree of entitlement to certain things. And that's something I know that our American colleagues do to a very large degree. So I think there's a number of issues that we can address and we can explore with veterans, the definition of veterans, the word veterans, and the eligibility criteria around it. It's one I think needs to be tackled. I'm not sure it's one for now, given all the other things we're also trying to do. But I'm conscious, as many are, that it generates a good degree of conversation and discussion.
So, and Zoe also has a specific point, which you may not be able to answer actually, but when we get the census, which is obviously going to be incredibly important, will her relatives who served, will it actually remind them what we consider to be a veteran? Because she's worried that they won't answer this question because, for example, they haven't been in, quote, in action. Will it say, if you spent a day in the services, please answer this question?
To be honest, Simon, I will need to check what the question actually is. But I think it is as far as I can recall, there's slightly more to it than "Are you a veteran?" I can't remember what the wording is.
Okay, I think we should follow that up actually, because it sounds technical, but it's actually not.
No, it's a very reasonable point.
Yeah, it's a very, very good point, and it will make a huge difference. If we get that wrong, we won't have another chance. Well, we will, but in another 10 years. So good point. Okay, and one last question for you. It's just, it may be slightly unfair, and maybe Kate might come in on this one, but it's actually an important question that I should have picked up earlier. This is from Rachel. Is the Veterans Aware accreditation, is that for clinical providers only, or is it for, more broadly defined support organisations that provide, lots of very, very important stuff, like, for example, well-being services that are not always defined as clinical? Do you know the answer to that? I don't.
Kate,
at this point, yes, Simon. Yes. And I will just say that and I know it's in the chat box, for the Operation Courage services, then it is the definition for veterans is 1 day, served 1 day.
Okay, thank you.
So the accreditation at the moment is mainly to do with clinical services, in the sense that it's GP accreditation, and it's also hospital aware accreditation and the acute trusts. Working very closely with COBSIO and many others to look at what that means to support, and I'm sure Charles will come in on that, what that means for our armed forces charities, but certainly with those services that are working on the well-being side of our collaboration services, and they are included in supporting the accreditation standard, absolutely 100%. And in fact, we're also working with CQC, Simon, to ensure that actually we can also move into a model with CQC around accreditation standards, not only for NHS clinical services, but also for services that are commissioned by the NHS and others to meet a standard mark.
Okay,
in my other ear, Simon, I've just been told that the question in the census doesn't actually use the word veteran.
Oh.
It asks if you have previously served. Okay.
All right. Well, I think we should talk about it, because that could be misinterpreted, couldn't it? Okay, but we've done that one. And then just to pick up here, I'm not quite sure which. So just to pick up one other question before we move on. This is for me. Another Simon Locke answered it. Someone's been asking more about Mark Foster, and apparently he's okay to answer these questions. Just to say, he was supported by the TILs and Walking with the Wounded, and Walking with the Wounded, of course, have been a very big collaborator in this mission, who worked with his local addiction services to support him in Tom Harrison House when he was suitable. And again, Tom Harrison House is a name and a service I'm very familiar with. So that's the answer to the specific question. As ever, it was a collaboration, NHS for TILs, Walking with Wounded, and indeed Tom Harrison House, which is a third sector, which does fantastic work. I've actually been up there. Right, okay, we move on.
The question precisely is, have you ever served in the UK Armed Forces?
Have you ever served in the UK Armed Forces? So that might be misinterpreted if you left during training, but you would classify as a veteran. Okay. All right. Anyway, I think we've done that, but we can discuss that. Well, it's done anyway, isn't it? There's nothing we can do about it. All right. Okay. And to answer Jim's question, I agree. The veteran definition should stay inclusive. Now, moving on then. So now, Charles Stanley, Dr. Charles Winstanley. Another one with a distinguished military career, another army type, etc. But he's morphed into a leading figure in the NHS We're on the board of NHS Lothian, the MOD, Scottish Government, and many other things. I didn't actually realise this, Charles. I noticed you also chair the board of the Academy of Medical Royal Colleges. And as a president of a medical royal college previously, I spent 3 years on that committee. That's probably the bravest thing you've ever done. Right, Charles, over to you.
Thanks very much, Simon, and delighted to be joining this session. I've been independent chair of the contact group since 2018, and I took over from David, who we've just heard from. Could I have slide 2, please, Milton? Just to remind delegates, this is the membership of the group. We've got all the main treatment providers, policymakers and researchers, and these are the 4 nations. Much of what we've heard about this morning, for the best of reasons, has been only. We also act as the COBSIO Mental Health Cluster. We're funded by Forces in Mind Trust, and the admin is hosted by Combat Stress. Could I have the slide off, please, Milton? Before I briefly describe the work streams, I'd like to highlight some sector strategic issues that are personal views. Milton, if you can turn that slide off, it would be helpful. Just looking briefly at the 4 nations of the UK, as we've heard from NHS England and from Kate, we've got the new high intensity service coming in, and this draws in charitable partnerships in a way that I think may indicate the future function of the third sector. And the prospect of his and the other NHS England products potentially morphing into a veterans mental health service for England in a few years, I think is really interesting. But it would be good to see a Veterans Commissioner for England. In Scotland, the new Scottish Veterans Care Network, it's not a clinical pathway, but it's a useful strategic alliance of mental health stakeholders that will reflect the covenant. There's been a Veterans Commissioner there for several years, Charlie Wallace, and there's also a Veterans Minister. Over in Wales, Veterans NHS Wales is a dedicated mental health system formed 11 years ago, provides 20 specialist veteran therapists to the health board. And that system seems to work well, and I gather the UK government's considering a Veterans Commissioner there, which is good news. In Northern Ireland, there aren't specialist veteran mental health services, but there is now a Veterans Commissioner, Danny Kinahan, and the new trauma network will treat veterans alongside other trauma patients, particularly those from the Troubles. Something about understanding the effects of service. Our research tells us that serving military, those not in combat anyway, have more mental health resilience than their civilian counterparts, but military recruiting is always drawn on areas of social.
Ooh. What just happened there? Charles.
Can you still hear me?
Oh, yes, you're back. Lovely. Good.
Okay.
Are you in Scotland?
So okay. I was just saying that for the serving military, although those not in combat have more mental health resilience than their civilian counterparts, the military recruiting is always drawn on areas of social disadvantage, and mental health issues can come with a recruit and may be contained or worsened by their service, but they're rarely quantified at the point of service entry and departure. So to connect with the covenant expectations, we perhaps need to better understand service attributable mental health conditions and understand an annual mental health fitness test is under consideration for the forces. I know, Simon, you and I've spoken about this, but I look to clinical colleagues to know whether a pre and post service evaluation has a role. Just a word on capacity issues. As you've heard earlier, there's been significant decline in the clinical capacity of the 2 principal mental health charities in 2020. That's Combat Stress Help for Heroes, mostly due to loss of revenue from donations. They've lost capacity for about 2,500 veterans a year. This is partly taken up by the independent sector. People like PTSD, Resolution and Icarus are examples of the 2 of the busier specialists. It's been partly taken up by the health service and it's been partly unmet. Icarus have told me they've seen an increase from just under 500 veterans in December 2019 to treating 1,300 December 2020. And any unmet veterans' mental health need, of course, has been exacerbated by the negative experience of COVID isolation and the limitations of Zoom-style support. On funding and coordination, I think there's a fairly awkward mismatch between the devolved health to the Four Nations and Westminster-led defence issues. And this means the veteran who looks to both regime is faced with differing treatment arrangements across the UK. And these differences in treatment products, pathways and services in the Four Nations can be quite bewildering, particularly for those who move between the nations, and they're unlikely to be standardised, so we need much better guidance for users. I do wonder whether the current confusing division of responsibilities shouldn't be replaced by a clear chain of political and executive responsibility with a budget for UK veteran mental health services at every level of delivery. Walter Busuttil of Combat Stress has gone a stage further, and he even argues for the integration of uniformed NHS and third sector clinical provision to look after both serving people and the veteran. And of course, in many instances, it's the same treating clinicians moving between the health service and the military. I do wonder whether in the future it'll be feasible for mental health charities to retain a clinical service. Increasingly, charities seem to be reliant on NHS contracts for revenue, particularly in England. The partner NHS mental health trusts have their own clinical provision and are not always looking for more than support and welfare services from the third sector. So if the 2 or 3 main charities can no longer be one-stop shops for mental health treatment and support, many will say that veteran reliance on the third sector is overdue and that the increased veteran focus of the NHS is welcome. So you've got a slide up here. I'm just going to touch on contacts activities. These are our objectives: to look at trends, to improve quality, to provide a platform for the statutory providers to tell us what's going on, to share arrangements across the Four Nations, particularly using case management, which I'll touch on in a moment, to promote integration, to find the research gaps, and to encourage organisations where mental health is not core business to become involved. And there's progress on our website. Could I have slide 4, please, Milton? I'm just going to go through the main work streams. We're gathering data. I'll develop these in detail in a moment. We're doing something about quality accreditation. We're trying to standardise the assessment of veterans across the system. We've got an exciting mental health information system to tell you about, and later I'll touch on the communications and the associates. So the data dashboard, when I took over from David, I remember sitting on a couple of meetings and he would call to delegates, where's the metrics? And there was a struggle to get people to produce the data. MOD are doing a brilliant job as a contact member. They're starting to gather a dashboard that brings together data on serving people and veterans from the MOD, health service and third sector. We've been trying to produce common reporting standards and working with the third sector to get their data to be, unlike that we've had from the NHS and the MOD, a bit more meaningful. We've run a series of online workshops with each charity member of Contact, and the MOD's been trying to sift through this demand, capacity and outcome data and to get some sort of sense to it. There's a lot of data in the charities, and what we've got to find is information that's consistent. And first of all, we've been looking at demand data, and that's going to be turned into a dashboard that will be of use to everybody. In the future, we might also look at data on families. Second, on that chart, you can see quality accreditation, and Kate touched on this. Hitherto, there's been no assurance of quality amongst providers of therapy for veterans outside the NHS. Indeed, in the UK, anybody can set up shop and claim to treat PTSD, and there isn't a programme for providers outside the health service. So this could lead to harm to users of unregulated services. So Contact are developing a programme using an existing accreditation service offered by the Royal College of Psychiatrists and tailored for this sector. And in time, we hope to have a quality kite mark to help potential users identify services that are participating in the programme that have been quality checked. We've got a clinical advisory group that's helping get the standards right, and we've got a first edition of those standards being piloted at the moment on a 1-year pilot. And we've got 10 people playing in that. It's across the sector. We've got 2 providers from NHS England, 1 each from NHS Scotland, and Wales, and 6 teams from the third and independent sector, all of different sizes. So at the end of the pilot in autumn this year, we'll have a set of quality standards that we can review and look at, and then we'll start the first full year of the scheme, autumn this year, for a year, when we can open up membership to any team from a UK Veterans Mental Health Service. And they are teams, not individuals, who are being accredited. So it's expected the first team will get their accreditation at the end of 22, and at that point the quality mark will be launched and publicised. DHSC has been paying for this, for which we're very grateful, and that means we can have a free pilot year and subsidise the subsequent participants. And we hope that interest in the kite mark will then act as a magnet for people to offer themselves to self-fund through the scheme. If I can just go on to talk about standardised assessment. This has been led for contact by our member NHS England, and Andy Bacon likes to call this the CAF, the Common Assessment Framework. At the moment, everybody puts their data in different ways, and so there's no consistency. The poor old veteran may be repeating their story as they meet the health service and charities. So by using a standard framework, we've got an insight into service use, and itself it's a proxy for needs assessment. We've got a full understanding of the types of patient, demographically and clinically. And it means that a shared assessment, common assessment, can mean research can look at need options and outcomes. So at the moment, that scheme is using the current assessment tools that the health service incorporate and those examine nature and severity of illness. We've already got the scheme shared with NHS England and Improvement and the Armed Forces Clinical Reference Group. So what the tool is doing, it's drawing on NHS measurement at the moment, NHS systems, because 80% of people are being treated by the NHS, and it's using their platform. And data collection is being managed by their own registry to capture outcomes. And these will be pull-down menus that can be easily used, not free text. So that's the common assessment framework that we're introducing. It's being piloted at the moment by Help for Heroes through till autumn this year. It's going to be used on TILS and CTS and HIS Pathfinders, and then charities are going to be mandated to use it from this April, and all new NHS contracts, this is England, and we're talking to the other countries, will mandate it from April next year. Now you'll see the join in this in the next item I'm going to go on to, which is the fourth point there, the Veterans Mental Health Information System. And my thanks to David and OVA for this, where we've had terrific support in funding it. We had a working group set up in 2019 and 20 with all the players in the sector, looking at the feasibility of linking veteran data for mental health services across statutory, third sector and welfare organisations in England, Scotland and Wales. Not doing Ireland yet, but it may follow. And OVA have now agreed to fund a scoping stage, which I'm told by the experts we call a discovery and tender phase for the project. So the concept's going to look at linking consenting veterans with selected organisations in mental health and welfare services in the statutory and third sector across England, Scotland and Wales. It may be technically feasible to bring Northern Ireland later on, but that's down to politics. So the envisaged system will provide a greatly improved experience for the veteran. There won't be duplicated records by service providers. It'll simplify the process of physical moves, and critically we'll get some data at the centre for policymakers and for governments. So at present, at the moment, data on individuals is held in silos. It's not accessible by the veteran, and it's certainly not interconnected. So this new system is going to overcome that. Parallel but related, COBSIO have been developing a welfare system to join up welfare services, and that'll be incorporated in the new system. So we're going to, through this new arrangement, if it goes beyond scoping and is introduced and fully funded, there'll be an immediate overview of the veterans dealing with the system, and users will have predetermined editing rights, and confidential data will be limited to overviews, not the detail. Consent will hopefully be sorted by veteran agreement at the outset to be involved with it, and it may even be an app-based system where they update it automatically. So the first stage of this just looks at mental health, which is the contact group's focus, but we're going to design it so it can be used for other physical conditions, and other clinical conditions later on. It's critical that this system doesn't seek to replace wholesale networks, but it will be embedded with them and be automatically used. It won't be a little used parallel data universe. Just a quick word on the third from end there, research groups. We have a contact research subgroup of 12 self-nominating organisations. We've got Forces in Mind, Anglia Ruskin and KCL as standing members. And this group's established in order to provide coherence across military health research. It's looking at relevant research for the benefit of contact projects, and it's identifying categories where there are gaps and suggesting where future research might take place. The group's already met 3 times, it's produced 3 reports, some areas that it's identified where there may be work needed, minorities' access to healthcare, the ageing veteran population with dementia in particular, service widows, and families and children. The group's also looking at postgraduate research across the UK to see whether there are opportunities there. Coming to the end of my points, the associate programme is intended to draw in organisations where mental health is a byproduct of their core business, and we've got a growing number of people joining that. www.contactarmedforces.co.uk is on the screen there. That's our new website. Thanks to Veterans Foundation for funding that. All our documentation can be found there. Thank you very much for listening. Simon, I'd be delighted to take any questions if we've got a few minutes to do that.
Okay. Thanks very much. I'm finding we've had about 300 questions now, and I'm finding it quite difficult to keep my head above water over them. But can I just ask you just to clarify a bit more on the information sharing aspects that you've said? I mean, there's an awful lot in your presentation actually, and I hope people realise this is really quite transformative compared to, you know, if we'd jumped back 6 or 7 years. So, but the information sharing seems to me to be both the most radical but also the most difficult. And at the risk of being a bit boring about it, can you just explain how you're going to manage the governance, and I know you know a lot about governance, the governance aspects of that, and I mean governance, not government.
It's very ambitious. I think it will need a governance group, Simon, to manage it. There are many issues. There are the cultural differences between the organisations that will play. There are sensitivities about data. Some of it's confidential. There will need to be very tight governance so that things like GDPR and access to the system is covered. As I said in the presentation, we envisage it only providing headline information, summary information, and only those who've been vetted and agreed will be involved in it. The critical players, and I know Kate touched on this earlier, the critical players in it will be the GPs. And we envisage using the veteran-friendly GPs under the Royal College of GPs scheme as the first cohort of people to be involved. We're well aware that in the 12 minutes or whatever it is a GP has with a patient, if they're going to use a system like this, it's got to save them time and help the patient, not add to their work.
Okay. Helen Hurst, who's clearly there's a nurse with a big background here, but there's also a couple of GPs also asking questions. A lot of them are asking questions about how would a GP surgery or setup, whichever they are in, how will they access these standardised assessments? And how will they even know about it? I mean, that's really a good question with GPs.
Well, the plan is certainly in NHS England is as each contract is developed, as I say, for that to be used. But the intention is to liaise with all NHS trusts and primary care to encourage them to start to use this system. It's going to take some years to roll out, I think. Yeah. And it may well be that the common assessment is overtaken by the information system that I've described. It may well subsume it with a system that uses GP's current IT to format it. So it may well be an interim measure, but I think it will take a while to roll it out, because clearly people have got to see the benefits of it to be worth reformatting their database.
Yeah, no, good point. Okay, let's go into a general discussion. So we still have Kate, and I believe we still have the Minister here, which is great. In fact, Kate just text me, say, yes, I'm here. Good. So one thing we haven't really touched on, I'm going to start with you, Kate, and also the Minister, is Op Courage and families. Lot of questions asking, will this make a difference to families? How will the work families be recognised? What about carers? Lots and lots of variations on that theme. Do you want to riff a little bit? Because I know this is an issue close to your heart. And then also anyone else want to contribute? So Kate, you kick off.
Yeah, certainly. Thank you for asking the question. It's an incredibly important question. And I know with a lot of the material that went out today that the focus is very much on the big V for veterans. And I think I said earlier that the reality is for any person to do with mental health, the needs and the support and of the family is absolutely essential. You don't get one without the other. And I often say that men and women's recovery is 60 to 70% also the support that they get of their family and not necessarily their clinician. So we absolutely planned and also continue to deliver the network of services under Op Courage, till CTS and HIS, with families and carers included as part of that menu of delivery and support. However, it is really important to say that after 3 years now of bringing that into the amazing place it is today to embed it as a long-term requirement, we recognise very clearly that we need to do more to support families and carers in their own right. And that's really the message that has come back from families and carers, mainly for two reasons. That's not about being negative, it's about being positive, but being realistic. Is that often when we're looking at services for the person who is the patient, in inverted commas, families sometimes step back from that and feel it's not for them, and they're maybe, going back to Charles's point, actually issues around sharing information, maybe concerns about how close or how far that may well be. And then also I think that actually some of the family and carer dynamics need to be seen separately in their own right, but also with the complexities of what that means with being in a military family in the past or present. So we've just done a major engagement with 1,300 family members and carers of all different areas of the armed forces community, serving reservists and veterans, to see and ask the question, what's important for you? What's the bits that we need to do and improve going forward? And actually, Simon, it wasn't so much the mental health services, it was more to do with, as you were saying earlier, the input and the support and the understanding in primary care, what that means, particularly around the continuity of services, particularly hospital services, particularly services for children. Let my loved one, kind of get the support they need from the Operation Courage services, but we also want to be seen as a priority in the commitment. So that's why commitment 2 in the forward view is purely for families and carers going forward. We have additional investment within the long-term plan to support the needs and the requirements across population-based, close to home, local, as much as possible. And that really is as part of our commitments, and as Sir Simon Stevens said, job not done yet, further work that we need to do. And massive thanks to many of the charities, the Armed Forces Families Federation, who are also doing some additional work on what that means for children and young people within that piece of work. Because yes, the simple answer is to say yes, we are supporting, and it is part of the whole delivery. But we need to be really and importantly realistic to say that we need to do more on that, and particularly better experiences around serving families when they're moving around and often having to share, which seems to be the theme of the morning really, their details again, and not to go back to the beginning of maybe a pathway of care, to stay in that pathway of care. If you move from Catterick to Wiltshire or Wiltshire to Catterick or whatever, how do you maintain that level of continuity? And as a veteran family, how do you, sit down with your GP, sit down with someone within a health and wellbeing service, in a hospital service, and actually feel that you are getting the understanding of what that really means to you as an individual. And often Often, not exclusively, of course, but often that is women. And how do women absolutely get that support and that need that they totally need as part of that family member when sometimes they've been in the background?
Obvious follow-up to that before anyone else steps in, it's from Mary, which is, I mean, a familiar question, I suspect, Kate, but how broad or narrow definition of families will that be? Blended families, ex-partners, wider families, etc., etc. If the definition of a veteran can be complex, the definition of a family even more so. How do you must have thought about this many times. Ooh, Kate, you've gone all silent. I think you muted yourself. Oh, that's better. You're back with us. Start
sorry
again.
about that. Yeah. An important question, and we often use the term modern family, which has been used by many of our colleagues that have been doing the work around the consultation for families and carers, and particularly thanks to the Public and Patient Involvement Chair, Nikki Murdoch. We have really, I think, and importantly, need to actually understand that our military families, past and present, come from all of the walks of life that every community does. What does that mean for families and relationships and separations? And there are many separations as well within all families, including the military family. What does that mean for the children and young people who are also have the identification and the worry of when their parents are away or a parent is away? What does that mean for obviously same-sex couples and the marriage within the community of the lesbian, gay and transgender families as well? And also, what does that mean when you have different cultures and different religions and beliefs? And people might think I'm just going through the obvious here, but these are the feedbacks that we've had to your question, Simon, that there has been for too long a feeling that the military family is, you know, a kind of 2.5 kids in the car in the backyard kind of element, which is the same for so many communities. And we really do need to look at this and address this within those complexities. Yeah,
and I know that you lead on all these areas. Anyone else like to come in on any family issues, because we haven't really discussed them before? Anyone? Charles, you're looking.
Yeah, I mean, I think it's just worth saying that quite often the very ill veteran is going to rely on the family to articulate their needs and circumstances, and I'm not sure that we always recognise that in the design of our systems. We assume it's going to be the veteran themselves we talk to, and so picking up Kate's points, we've got to be sensitive to whatever form that approach might take, the circumstances of that family member.
Okay, and David?
No, I completely agree. I mean, I think that for too long the sort of families, however defined, and I think a loose definition is a better definition in the times we now live. For too long they've been, one could say, an afterthought, still felt treated a little bit like the camp followers. And I think we have got to change that. And changes are afoot. Kate's described some great work that's going on there. At the Veterans Advisory Board, we have a couple of people who've got a really specific interest in military veterans families and ensuring that they're wrapped into the work that we do as an organic part of it, and absolutely not as an add-on at the end. And I think that's so important, and we will seek to sort of pursue that as we go forward.
Okay, Minister, I'm not sure if you're there or not. If you are there, do you want to? Yeah, I've heard you talk. Oh, you are there. Great, good.
What I'd say on this is I'd reiterate what David said. Families are absolutely central to this, and Charles made a really important point that actually, the role they play in getting people to come forward for mental health treatment is absolutely vital. So, one of the key things we did when designing Up Courage, and the group that Kate worked with, was talking about how we kind of make, this wasn't designed so that I could understand it or someone in the military could understand it. It was designed so families and users could understand it. So, look, my commitment to families is as much as it is towards veterans. There's some brilliant initiatives going on, but I think we can clearly always do more. I think there are offers out there, but it's about singing the tune and getting people to understand what's available, and that, as ever, is a huge challenge.
Okay, and a specific question. Oh, sorry. Somebody wants.
think you've got a bit of an echo, Simon.
I've got a bit of an echo. Okay, it's me then. Okay, so I like specific questions. This is very specific in relation to carers. Will you be working with social care who have duties to support carers under the Care Act 2014? Oh, that's sweet, Johnny. I saw that. Okay, that might be for you, Kate. You're the expert on the Social Care Act.
Sorry, can you just repeat that? I got wonderfully, for people who aren't on the bigger screen, a beautiful shot of Johnny and his daughter having a lovely natter just at the time we were talking about families. So it was absolutely fantastic. So I'm really sorry, but I was smiling too. Could you just repeat the question, Simon?
Okay, I'll do that one again. Yes, of course, not everyone could have seen that, but a very beautiful little girl shot into screen wanted some attention. Okay, it's from Sharon in relation to carers. This is about Up Courage and working with social care. You have duties to support carers under the Care Act 2014. Someone knows what they're talking about.
Yeah, absolutely. And the Social Care Act 2014 has been a really important one for many of our men and women who probably sit slightly outside how a lot of our local authorities who have the responsibility for social care within that act understand that pathway of care for maybe men and women that are going, particularly I have to say, in and out of the criminal justice system, within the veterans community, and the transition particularly from serving to civilian life. So it is absolutely part of the menu of services. One of the elements within the new high intensity service, and I think actually Johnny touched on this in his video, but I know the video wasn't working too well. Sorry, the minister touched in his video, was that we really have wedded into the high intensity service for all of our service specifications the need to do the care coordination of men and women as part of health and social care. That's absolutely obviously within all of the Operation Courage elements, but the feedback when we were moving into a more intense service model with high intensity service, particularly in crisis, is where maybe people had fallen out of the need and the understanding of social care, particularly in safeguarding terms for adults.
Yeah.
And that was really where and how we want to build on that. It's still obviously very early days, but that was particularly part of the model and also as part of the service specification with all services. And many thanks to many of those that are picking it up now.
Okay. And another fairly straightforward question, again, someone knows the jargon, but they've come as anonymous, is when and where will you be publishing details of the new pathways around Up Courage? Minister, is that for you?
So details available today on the website, but clearly, we have a job of work now to go around the country. As I said earlier, for me, there's no reason why a GP surgery can't become a veteran-friendly GP surgery, or why NHS trusts are not veteran accredited. So, what we had to do is design the product, which we've done with Kate, get it out the door, and now we need to go out and sell it and make sure everybody in this country knows where it is. Kate, do you want to add to that?
Yeah, I think the other thing about publication, because publication is a very interesting word, and as my boss, Sir Simon Stevens, would say, we don't actually publish that much stuff. Lots of stuff is available as part of information and guidance, but publication is another kind of real set of commitment and importance. And so the forward view, which is, as I've said, from serving to civilian, is published. It actually is published from this morning at 10 o'clock this morning. So I apologise because, many people, including yourself, Simon, won't necessarily have seen that publication because of the due process of publication. But that is, as the Minister said, available from today. We obviously have a task now to make quite sure that that is distributed. It is a forward view. It's got no timeline. It's about, we've got a lot of time to get this right. But we don't want to go backwards, and that's absolutely really key on this as well. The Operation Courage element is really clearly looking in the next year also, going back to one of the questions from one of the staff members within TIL CTS and high intensity service, how we can build on a more collaborative, formal, sustained model. And that's the part that is in the long-term plan about that pathway, both pre, post and serving, and how those services will evolve within that Operation Courage, Op Courage model, in order to bring it all together. And that was the feedback from the service users. I know there's been lots of questions on it. It's complex, which one, which number, single point of contact, close to home, looking at individual assessment and then making quite sure that the pathway follows your need, not necessarily it's about which front door you go in.
Okay, so actually that was quite important. I know these people get very blasé about things, but a publication is important because it sends something that can hold all of you on the screen to account to all of those people asking questions. Someone just put up the link, I think, to the NHS England statement that must have just come out from, if this was done at 10 a.m. So there's a link there, and presumably those who want to, learn more will be able to get the document as well now, presumably on the same place. So that's quite, I heard you discussing it earlier actually, and making sure it was going to be published, which you were clearly in favour of, and as was Simon. So that's quite an important thing actually to have happened today, particularly as time goes by, because you can see it and see how well everyone is doing. Now, one question a few people have asked, I think with slightly tongue-in-cheek at me, but asking about the research strategy for the OVA, because you mentioned it briefly there, David, but saying, how are you going to ensure that this will be inclusive across the whole field and not just on one or two well-known providers? You need to get your mic on, David. Still need to get your mic on.
So that's right. I'm back. I couldn't get a message out of the way to see my mic, but there we go. I'm here.
Actually,
yeah. I mean, we absolutely have the intention to have a big tent approach to this, and to include all those relevant academic institutions in both the consultation around what the research strategy might comprise, and also opening the doors to a broadcast of players to bid to undertake the work. I mean, I can't do much more than make that assurance, frankly. That's the intention. I mean, I think I've got a strong theme in what I said, that collaboration and increasing integration of services is as far as I can see the way ahead. And in terms of our research program, that absolutely applies too. We want to have a big tent, bring as many players to bear on this as we can, and ensure that we're getting the best possible research to inform our forward efforts.
Okay, and I think this, you've half answered this one, but it's from Faisal Sethi, which is, how can collaborative groups seek accreditation? I think he's talking about GP groups here, because a lot of GPs are now in much larger groupings, and ditto hospital providers. Do you want to explain a little bit more how that will work?
The mechanics of how GP practices are accredited, I'm not familiar with. I don't know if Kate knows the answer to that.
Kate, do you?
Yeah. So as was said earlier, the accreditation for the Royal College of General Practitioners and NHS England for GPs now has a formal accredited model of standards, where GPs and GPs practices can sign up either on a voluntary basis, but we will also, as said earlier, obviously be supporting all of our GPs and practices. Quite often it actually happens when a group of GPs come together in an area, because it makes sense to do that for the population. It's supported by a team, it's supported within the standards, but also looking not only at the GP, but what that means to the receptionist, to the whole element of the practice, because that's, again, back to families and carers, some of the important element. We're working very closely with our acute trusts and our hospital trusts for the Veterans Aware accredited programme. We've just committed additional funding to support all of our trusts to receive the Veterans Aware standard and requirement. And within all of those, what we actually, is part of the accreditation, is the ability to demonstrate working with the voluntary sector, the third sector, peer support and lived experience. So that's very much about, from the NHS position, the side. Obviously, there are more formal elements, and when there are different clinical standards like the Veterans Trauma Network or the Veterans Mental Health Services, I won't go into those, because I think the question was particularly around the accreditation of Veterans Aware and Veterans Friendly.
Okay. So we're moving towards the end now. So one last roundup from the four of you of one thing from your presentations you really want to bring out. I'll give the Minister the last word. Charles, what do you think is the one thing you'd like us to take home from what was a very exciting programme? Wow.
Well, I would simply like maximum energy in bringing together this data, so that the veteran only has to tell their story once. And I think it will challenge a lot of organisations who jealously guard their culture and their way of doing things. I think there's going to need to be some real energy and goodwill put into that.
Okay, David.
I think the point I'd pick out most is let's look at the financial pressures imposed on us all due to COVID as a catalyst for change, to bring us closer together, to have people look at and work together and integrate over time, rather than perhaps the instinctive reaction, which is when things are tight, you turn inwards and you sort of go into protective mode and survival mode. Let's look out and see how we work together better to deliver a properly integrated and really good service into the future.
Okay, Kate.
Before I do that, I've got an amazing team that have just literally informed me that the Operation Op Courage leaflets have just been updated from the conversations on today's call.
Really?
So that's how good we are. They were available, but we've just changed them because of some of the questions and comments around pathways. So they will be available, but we're just updating them, just so that question earlier. My final comment really is about the person, is about the individual. We're only doing this because I want the same service that I want for my daughter, for my mum, for me, and what that means for military families and veterans, and understanding some of those differences, but also some of those complexities, but also some of those joys as well of really getting your life back where you want it. And as one of our clinical leads said on the video that we didn't see, it's sometimes a challenge, but it's really a massive joy when people change people's lives, both clinically, socially and practically, but we've all got to get together to do it. Thank you.
Thank you too. Okay, Minister.
No, just a huge thank you to everybody for taking part. You know, I know that it's a challenging environment, and certainly David and I are engaged in a sort of day-to-day challenging fight, if you like, to get this on the agenda and to make it happen. Just a huge thank you to Kate and her team for what they've done, to Charles, to Forces in Mind Trust, and of course to you, Simon, and the team at King's for putting it on. You know, and I look forward to, you know, seeing where we are in a year's time. It's important we keep coming back and marking our progress with stakeholders. It's no point us thinking we've done a good job. We need to do that with stakeholders, and I'm more than happy to do that. So thank you for everything today.
Okay. And on the subject of videos, we will be sharing Katie's video on this website. Minister, we do apologise for the slight problems you had. At least we got your pulse racing, but you also reacted like the true professional that you are. And I still think that being live is always better than even. Yeah,
you didn't need your video.
I know, even that little free sort of excitement.
I had to get dressed pretty quickly.
Indeed. So thank you to everybody for taking part. Now, of course, this is not even the end of the beginning of this series, because we are pushing our Veterans Research Day now into 4 sections. So this will be the same time next week. We will be back. Hopefully you will be back. It'll be on Science and Function. Next session on the 11th of March. Register by Eventbrite. And again, of course, it is all free. Thank you to all you asked the questions. I'm sorry we couldn't answer all of them. It was completely impossible. But if you want instant feedback and impact to get the information on courage changed, even as you were speaking or texting or emailing, is really quite impressive. So my thanks to all the speakers. Thanks to you for watching. Apologies to those that we didn't get round to, but you'll be 3 more goes that you will have to get your other questions answered. Fortunately, not me in the chair. I also need to get a cup of coffee and get my own pulse back to normal. Okay, everybody. And thanks, Johnny, to your lovely daughter, who we can hear. That's sweet. I love it. That's the one bit I will miss when we go back to normal working. I will miss some of those unsolicited interactions. I won't miss them very much, actually, but I'll miss them a little. Okay. Take care, everybody. See you next time.
Bye-bye.
Bye-bye.